Hi, I'm Victor Martinez-Glez, clinical geneticist from the Institute of Medical and Molecular Genetics at La Paz Hospital in Madrid. First of all, I want to thank the organizers for inviting me to this fantastic conference. I will talk about the genetic causes of GLA. Generalized lymphatic anomaly, GLA, is a rare congenital vascular disorder characterized by diffuse or multifocal lymphatic proliferation that infiltrates and affects different sites, including viscera, skin, and bones. The bone lesions can be seen as multiple intramedullary cystic lesions, normally without cortex involvement. GLA may be present at birth, but usually becomes evident during the first 2 decades of life. The presence of chylous fusions is unfortunately frequent and is associated with a poor prognosis. The genetic cause of GLA was described by our group 2 years ago, but a few years earlier, it was already clear that the pattern of corporal distribution of the lymphatic malformation and the osteolysis was compatible with somatic mosaicism. Unlike traditional genetic alterations, in somatic mosaicism, the pathogenic variant has not been inherited and is not present in all body cells. Instead, the variant appears during embryonic development. Thus, the number and type of cells affected will depend on the time and place in which the variant arises. There are several possible combinations of time, numbers, and locations, and this is how we explain the tremendous clinical variability in patients with GLA, as also happens with other diseases caused by somatic mosaic mutations. Somatic mosaicism makes the molecular diagnosis difficult in patients with GLA, since the variant is generally not detectable in blood samples. It is only possible to detect the variant in samples of affected tissue, and those samples are obtained by a very invasive methods. And it is not always possible to obtain those samples. What's more, when this sample is already available from previous surgeries, it is usually embedded in paraffin, so it can be studied by pathologists. But in these samples, the DNA is degraded and makes very difficult to detect variants present in a very low percentage of cells, even when we talk about affected tissue. Further, if the sample embedded in paraffin is from bone, it is almost impossible to obtain DNA for testing. In the work that we published in 2019 describing the genetic cause of GLA, we studied 9 patients with GLA. The clinical diagnosis was based mainly, but not only, on the presence of lymphatic malformations and lytic lesions in bone. You can see in the figure the presence of large lymphatic malformations, some with skin involvement, and in one of the patients with the lymphatic malformation in the humeral region, even caused intralesional hemorrhage. Multiple lytic lesions can also be seen in regions that are associated with that lymphatic malformation, and here we can see that osteolysis in pelvic bones, arm, and spine. But it wasn't easy. At that time, we knew that our target cells, the ones with the mutations, were probably the lymphatic endothelial cells. So we isolated them from a lymphatic malformation in a patient. However, from all the cells of the lymphatic malformation, the lymphatic endothelial cells represent less than 10% of the tissue we call affected. So this gives an initial idea of the difficulty of detecting mutations present only in a small group of cells. Thanks to the isolation of those lymphatic cells, we were able to detect variants in PIK3CA. And this is a gene we already knew is the cause of overgrowth syndromes and different vascular malformations, including isolated lymphatic malformations. Thanks to the fact that we were able to improve our capacity to detect variants in low mosaics using the NGS technique, we could detect pathogenic variants of this gene in 5 of the 9 patients studied. And today we have detected pathogenic variants in PIK3CA in 9 out of 15 patients in which we have suitable tissue samples to study. Of course, it was easier to detect the variants in isolated lymphatic endothelial cells since they were in percentages of up to 33%. But finally, we also achieved it in samples of both fresh biopsies and paraffin-embedded tissue, also generally in lower rates, down to 1%, which are more challenging to detect. The variants were not detected in blood samples from the same patients. What we detected in the first patient in this table is also interesting. Despite that the tissue sample was embedded in paraffin, the dissection of specific areas marked by the pathologies allowed us to detect the variant in a relatively high mosaic, 22%. On the other hand, in the more than 34,000 times that we read that specific genomic position in bone and fascia samples, we detected the variant in approximately 0.01%. As I will show later, this could be showing the presence of few cells with the mutation in bone tissue. Unfortunately, we cannot say this, as it could be caused by what we call technical background noise. This is small errors that the NGS technique introduces when studying the samples. But it does demonstrate two things. The first one is that sometimes it's really difficult to detect this variant. And the second, that currently the need for a second sample is unfortunately frequent when the first sample was negative, independent of the origin of the first sample, if it is fresh tissue or paraffin embedded. Once the gene was detected, it was necessary to verify that it really was the cause of GLA. So we started a great collaboration with Dr. Dellinger, you all know him, to develop an animal model that finally showed that this mutation caused lymphatic dysfunction and dysplasia in mice. You can see in the images on the right how the lymphatic nectar is completely disorganized. Dr. Dellinger found that mice with the mutation have lymphatic vessels in the bone, and that's something that shouldn't happen. As I mentioned before, this could explain the few cells with the pathogenic variant detected in the bone sample from one patient, but it could also help us understand the osteolysis process. In fact, in a recent paper, Dr. Dellinger shows that bone lymphatics develop when regional lymphatics grow, breaking the periosteum and then invade bone. The animal model also showed that the use of rapamycin, a known inhibitor of the abnormal growth caused by mutations in PIK3CA, prevented the onset of lymphatic dysfunction and dysplasia. And also, the rapamycin was useful to improve the lymphatic dysfunction and dysplasia once it was already present. So, today we know that GLA is caused by activating mutations in the PIK3CA gene, that its molecular diagnosis due to the mechanism of somatic mosaicism is still complex, that we do not achieve good molecular diagnosis in all patients, and this may be due to the type of sample studied, the possible existence of other causes, or sometimes because the clinical diagnosis is just not easy. Happily, the ability to detect low mosaics by NGS and to obtain DNA from affected cells where that DNA is circulating in the blood or within the lymphatic malformation itself is improving day to day. Thus, that will help us avoid using invasive methods. We also know that the detection of the specific mutation allows the use of specific drugs, the so-called personalized or precision medicine, and that these drugs will be better, more specific in the future. And finally, all this is possible thanks to the international research effort of the scientific community with the vital impulse that comes from organizations such as the LMI and the LGDA, all with the aim of improving the diagnosis, follow-up, treatment, and ultimately the quality of life of people affected with GLA. Thank you all.